Yes, sir. You can start, sir.
Okay. Good afternoon to all the UK faculty and the attendees, and for the Indian counterpart, it is good evening. The IAE BSc webinar today is on prosthetic heart valves. Prosthetic heart valves are becoming more and more important at present because of two reasons. One, in the developing countries where rheumatic fever is still a problem, they undergo valve replacement, and some of them may develop problems related to prosthetic valve. While in the Western world, the degenerative aortic valve is the most important reason for valve replacement. On top of that, there is the transcatheter aortic valve replacement, and the problems of the valve replacement through the catheter technique is slightly different from the surgical valve replacement. So I would presume that today's webinar is going to be extremely useful because of the fact that prosthetic heart valves are on the increase and they come with a lot of problems. With these introductory comments, I request my counterpart, Dr. Sean Robinson, to give his comments and to invite the first speaker to deliver his talk. Please, Dr. Robinson, please.
Thank you very much, Professor Manjuran. It's a pleasure for the BSc to collaborate with the Indian Academy of Echo on this highly important and needed webinar on the assessment of prosthetic heart valves by echo. We've got an eminent faculty here to give us some really interesting presentations and case presentations, and I'm delighted to start by introducing Dr. Jim Newton, who's our first speaker. Jim is a consultant cardiologist at Oxford University Hospitals and at the Cleveland Clinic in London. And Jim is the lead author of the new BSc guideline for the assessment of prosthetic heart valves, of which he's going to give us an overview of his recommendations. Thanks, Jim.
Thanks, Sean. And thank you for the invitation, and good evening to everyone listening. So I've been asked to give an overview of the soon-to-be published prosthetic valve guideline. It's a bit too long to cover in detail in just 10 minutes, but I want to give you a flavour for what the guideline will bring to those who wish to read and digest it. Why do we need the guideline? Well, you've heard some comments already about the importance of prosthetic valve assessment on echocardiography, and we have to recognise that there's nearly an exponential increase in the type, variety and nature of prosthetic valves being implanted both surgically and with transcatheter techniques. And it's extremely challenging for anyone to keep up with the range and type of valves available and how to assess them carefully and accurately with echocardiography. And one of the main challenges for those people undertaking echocardiography is it's all too frequent that the patient arrives with a scar on their chest, but little other information about exactly what valve they have implanted. And what the guideline will hopefully help those doing these scans in achieving is understanding where they're looking at normal prosthetic valve function or extremely abnormal prosthetic valve function. This pair of images at first glance look quite similar, and I've shown you a four-chamber with colour and some Doppler. Of course, the experienced eye, I think everyone can spot which of these hearts is sick and which of these patients is actually in severe trouble. But you do need a framework and a way of working through the echo data in a stepwise fashion to understand that the image on the left is showing you normal function of a single tilting disc valve, whereas the image on the right is showing severe acute dysfunction of a thrombosed bileaflet valve. And of course, it always becomes much more obvious when you take additional imaging, such as a TOE. So the purpose of the guideline is really to help people walk through how to assess valves. These are all the authors that have contributed. I'm sure many of these names are familiar to you. And everyone's given their expertise and their opinions on how to work through all of the potential prosthetic valve challenges we might face. The guideline is set out like this. The first section is on the general principles for echo assessment, the common themes that are true for any prosthetic valve in any position. There's then a discussion about the common ways that prosthetic valves fail. and what the clues for that type of failure might be. And it then progresses, as you might expect, into chapters around prosthetic valve position. So prosthetic aortic valves are covered first. And as we've heard, a prosthetic aortic valve is the commonest prosthetic valve we encounter, certainly in the UK. And we walk through the principles behind obstruction, and then the clues and how to assess and how to quantify regurgitation. There's then a brief section on aortic valve repair, because that's a less commonly performed procedure, but still important to understand. And then we move on to mitral valves, and again, it's broken down to obstruction and regurgitation. And again, the sort of hard parameters and the more subtle clues. We then cover mitral valve repair before we move on to tricuspid valves. Again, a rarely implanted prosthetic valve, but we do encounter patients with abnormal prosthetic tricuspid valves, and then an overarching conclusion. I think it's just worth clarifying that what we don't cover, because these will appear in other guidelines, is pulmonary valve, prosthetic pulmonary valve assessment, because that will largely fall under an ACHD themed guideline, and it's rarely performed in non-ACHD patients. And we don't cover any of the other transcatheter interventions to mitral or tricuspid valves. We do cover TAVI, but not other structural interventions. These will be covered in a forthcoming sort of structural intervention type of guideline. And what the guideline does not contain, because it's really not practical to do so, is exhaustive tables like this that you may have seen in other guidelines. Because with the range, size, and variety of position of the valves available now, these tables become very unwieldy and I think difficult to use. What the guideline does do, though, is signpost you towards the BSE echo calculation app, and in particular the prosthetic valve section, which contains an updated data set to allow you to understand what you should be expecting to see with that particular size prosthesis in that position. And it's also, like many other BSE guidelines, image-based with lots of echo examples, and it's clearly broken down by each parameter for each valve with example measurements and examples of correct measurements, and also examples of where measurements can be done erroneously that might cause misinterpretation. The author group spent quite a lot of time working on what we hope are helpful algorithms to allow you to walk through your data set. Here's an example for aortic valve dysfunction. Look at the key parameters, consider whether this is definite obstruction, possible obstruction. Could this be aortic regurgitation masquerading as high gradients? Could this be patient prosthesis mismatch? And I think these will be helpful quick references for those people undertaking the scans. And there's then practical examples of sort of case-based work-throughs, examples of pathology, examples of prosthetic valve abnormalities, and examples of patient prosthesis mismatch, as you see here, clarifying the agreed and standardized methodology for your measurements and assessments. TAVI is covered in some detail, and because there are differences in how you assess TAVI patients. And the challenges with TAVI are understanding whether the regurgitation we see frequently is pathological or not, and whether the valve is functioning normally. And again, there are visual guides as to how to measure important parameters such as the LVOT diameter, exactly where you measure it, and then again where you do your Doppler measurements. As I mentioned in the first few slides, aortic valve repair is covered briefly. There's a sort of minimum data set outlined again in a tabulated format with example images about what to evaluate, what to measure, and what to consider. And then the other sort of large section is prosthetic mitral valves, where we know one of the major challenges is the shadowing, particularly for mechanical mitral valves, and the difficulties in understanding whether there is regurgitation or obstruction. And again, in the same format, we walk through normal findings, normal appearances, clues for pathology, and then what data sets you're going to use and how you're going to interpret your Doppler data in particular to understand whether the valve you're imaging is functioning normally or not. We have a slightly longer flow chart for mitral valve gradients because it is a little more complex than on the aortic valves. And again, the BSE app is your friend at trying to understand whether data you've obtained is relevant and correct for that patient. We have summary tables, which again are sort of quick references that give you broad outlines about whether you're looking at a normal mitral valve, a possibly obstructed mitral valve, or a severely obstructed mitral valve. And the guideline is full of explanatory graphics to clarify the imaging claims, the anatomy, and the optimal assessments. Mitral valve repair is clarified in the same way as aortic valve repair with a visual guide. And then we follow with what we consider to be the recommendations for surveillance of prosthetic valves, because this is a common question that comes up in many centres about how often valves should be monitored and followed. It's a long guideline, it's 12,000 words, but it's also image heavy with over 120 echo images and a lot of tables and flow charts to try and make it simpler and easier for those reading it to follow. And it's got very focused references. There are only 33 references. I tried to choose the most relevant reference for each section. I'm just comparing it with the American Society of Echo guideline on prosthetic valves, which has over 230 references, which, of course, these are very helpful as a resource, but these are the ones that I think you would want to go away and read if you wanted to explore that part of the guideline in more detail. So my final slide here really is just to thank the author group who've all put an enormous amount of effort and work in producing these chapters, and it's a guideline that I'm proud to have led on, and I hope it'll be with you later this year. That's my email address if any of you have any comments or questions after this, and I'll thank you for your attention. Thank you very much.
Thank you.
Excellent.
Well, yes, please. Thank you, Dr. Newton. We can have one or two questions or comments from the other faculty, or even from the invitee. If there are one or two questions or comments, we can accept that before we go to the next talk.
Jim, from the perspective of prosthetic valve stenosis or obstruction, for us to confirm that valve function is normal or abnormal, we often rely on knowing what the valve size and type are, which people rarely have access to. Any tips for how people investigate or interrogate valve function without knowing the details of the valve?
Yeah, that is covered in one of the sections, because there are certainly thresholds where any valve will clearly be abnormal irrespective of its size and type. But we also at the start make it very clear that if we're being asked to undertake an echo as a routine echo in a prosthetic valve patient and the make and model are not provided, we really should push back and not undertake the echo until we have that information, because you're putting an unfair burden on the person doing the echo. And it's easy then to potentially misclassify that patient as having obstruction when they might actually have a normally functioning small valve. So of course, in the urgent or emergency setting, we cover potential clues for obstruction in the absence of knowledge of valve size and type. But I think we should all adhere to the principle that we should have that information, even if it means turning the referral away and asking for more data to pretend. And usually if people try hard, they can find some data somewhere that clarifies exactly what the type of valve is.
Yeah, it's usually available somewhere, isn't it? So I think.
Dr. Newton, I would like to know, following a valve replacement, what will be the most ideal time for you to interrogate these patients, transthoracic echo, transesophageal echo, to have a baseline data? Do you do that, or you do an echocardiography routinely when the patient comes for a follow-up? What is the timing? Do you have any pattern?
That's a good question. So we had to sort of separate those slightly into surgically replaced heart valves and transcatheter valves. Certainly, if you have a surgical valve replacement, you shouldn't really do the index baseline assessment that defines the function of that valve in that patient until at least 6 weeks post-surgery, because of the confounders of atrial fibrillation, anemia, pain, wounds, dressings, etc. If you do the baseline echo too early, you may get slightly misleading data. That's obviously not the case for a transcatheter valve replacement, where you don't have those additional challenges usually. So the index echo can be performed after a TAVI, within the first few days, and that can act as their baseline study. But surgical valves, your baseline data should be several weeks after surgery.
Thank you. If there are no more comments or questions, can we go to the next speaker? Okay. I shall invite the next speaker. This is Dr. Shanmugasundaram. He is a senior consultant in Kuppaswamy Naidu Hospital in Coimbatore, and his areas of interest are heart failure and echocardiographic assessment of the cardiac function. Dr. Shanmusundaram, the floor is yours.
Yes, sir. Is my slide visible, sir?
It's visible. You are audible as well as the slides are visible. Slide is visible.
Yeah. So I'm just presenting an unusual cause of mechanical prosthetic dysfunction, a case which I recently came across. Yeah, so it's a 28-year-old male, a known case of ventricular septal defect with aortic regurgitation. He underwent a surgical closure of VSD with aortic valve replacement with the 25 mm tilting disc valve in 2010. He was now admitted with exertion breathlessness for the past 2 months, which worsened since a week. No history of fever. He was on oral anticoagulation with therapeutic INR. At the time of admission, his heart rate was 90 per minute regular, and he had wide pulse pressure, and valve clicks were slightly muffled, and early diastolic murmur was heard at the left sternal border. Respiratory system was clear. This was his chest X-ray at the time of admission, which showed cardiomegaly with evidence of pulmonary venous hypertension. We could see the prosthetic valve swing ring as well. Basic blood investigations were fairly normal, with the total count being normal, and PT-INR was therapeutic, and NT-proBNP was significantly elevated. This was his transthoracic echocardiography, which showed, I'll just realize a pointer. Yeah, what we can see is this is the prosthetic valve located here, prosthetic aortic valve, and there is a soft tissue density structure which is noted in the left ventricular aspect of the valve, which is mobile as well. A closer look at the abnormal structure, what we could see is it is a hyperechoic structure, which is quite linear and fairly straight, and it is quite significant shadowing, which raises the possibility that it could be a portion of the leaflet itself rather than any thrombus or pannus. What we commonly notice is a tilting disc valve which opens only into the aorta. The leaflet should not protrude into the LVOT. It should not cross the swing ring, but it does cross here. And there is evidence of significant intravalvular aortic regurgitation. And left ventricular systolic function was fairly normal. And short axis view does not reveal any additional information other than what we saw. And apical views showing that LV systolic function is normal. There is evidence of left atrial enlargement. What we can notice is a significant aortic regurgitation. In the apical long axis view, it shows that it is likely to be a significant intravalvular aortic regurgitation. And this is a color continuous wave Doppler across the aortic valve. This is the antegrade flow. What we could see is the peak gradient is 40 and a mean gradient of 24. If we see the shape of the trace, it is fairly triangular and early peaking with an acceleration time of 61 milliseconds, which is short, probably suggests that the high gradient is not really due to any organic obstruction which is happening to the valve, more likely related to the aortic regurgitation high flow across the aortic valve. And this is the AR spectral trace. What we can see is a dense trace with a sharp deceleration slope, and it is falling short of end diastolic period, suggests that there is elevated end diastolic pressure. And this is the pulse wave Doppler across the descending thoracic aorta, shows that there is a significant diastolic flow reversal. And again, the diastolic flow reversal stops short of the end diastole. The same thing happens in the abdominal aorta as well. So we just try to compare the images which was acquired in 2022, where we could see that the leaflet movement was fairly normal and there was no abnormal structure in the LVOT. There is no portion of the leaflet which is crossing the swing ring towards LVOT, in contrast to the current image. This is seen in the right side of the image here. So the differential diagnosis we had at the point were a probable structural valve deterioration, which could either be a leaflet or a occluded fracture with severe intravalvular aortic regurgitation. Though we couldn't conclusively say no for abnormal structures like vegetation, thrombus, or pannus at that point of time. went ahead with the transesophageal echo. This is mid-esophageal 5-chamber view. What we could see is again a linear straight hyperechoic structure which is seen protruding into the LVOT. Raises the possibility of a portion of the leaflet itself because it causes significant shadowing also. And there is significant intravalvular, aortic regurgitation noted here. And what we could see is the echolucent structure. It is seen close to the aortic root, which seemed to be communicating with LVOT. What we could see the color flow probably during systole, it goes into the abdominal structure. What we see here. This is the short axis at the level of aortic root. This is the valve here, and the location of the non-coronary sinus. We could see an echolucent structure which could either be a dilated sinus or probably a fistulous communication which is between the aortic root and LVOT, which needs further delineation. And this is the explained sweep across the aortic sinus and aortic valve. Again, what we could see is a linear structure which is protruding into the LVOT, as we saw in earlier images. This is mid-esophageal long axis. Again, fairly confirms the same finding. Probably a portion of the leaflet is protruding into the LVOT with significant aortic regurgitation, likely intravalvular. So he had recurrent chest pain and evidence of dynamic ECG changes during hospital stay. The fluoroscopy was not done because like this particular tilting disc valve, the disc is not really like radio opaque. So we didn't try that, and blood cultures were sterile. Procalcitonin was negative. Since he had chest pain, dynamic ECGs, we didn't want to look at the coronary anatomy. We didn't want to try a conventional angio because since we were suspecting a leaflet fracture, which might destabilize the fractured leaflet. So we went ahead with the CT, which showed the normal coronaries. Unfortunately, we couldn't really look at the integrity of the leaflet because of the artifacts by the sewing ring. So the working diagnosis at that point was a probable structural valve deterioration, which could either be a leaflet or a fracture. Severe intravalvular regurgitation, episodes of coronary ischemia, probably either a coronary embolism or ischemia related to aortic regurgitation. Normal coronaries, probable paravalvular fistulous communication, which we were not sure, and no evidence of active endocarditis. So since we had a suspicion of the fractured leaflet, we planned for early surgery, which in fact confirmed our suspicion that the leaflet was really fractured, and this was probably freely mobile. Lucky for the patient, it didn't get completely fractured, and device didn't embolize, which would have been a catastrophic event, which might have ended up in mortality also. And unfortunately, surgeon really couldn't confirm any paravalvular fistulous communication, either communicating to the aortic root or from the LVOT. So this was the postoperative image where the normal prosthetic valve function with good antegrade flow, no evidence of significant aortic regurgitation. We'll just quickly go through the another case, which we came across again. So it's a 55-year-old lady, post double valve replacement, done 12 years back with aortic valve being tilting disc and mitral valve also. Atrial fibrillation with controlled ventricular rate. Now presented with exertion breathlessness for 3 months. The pansystolic murmur at apex. This was the initial parasternal long axis view, which again shows that there is a significant mitral regurgitation, likely intravalvular, and this was a continuous Doppler jet. And short axis again shows similar significant mitral regurgitation with a dense jet here. When taken with the transesophageal echo, it shows that there is a suspicion of an echolucent area noted within the leaflet itself, and what we could see is a significant intravalvular regurgitation with a Doppler confirming the same. The 3D gave us a clue. This was 3D without color. 3D with color shows that the jet is not really from anywhere the paravalvular area, right from the middle of the disc. Confirms that it's an intravalvular regurgitation right from the mechanical damage of the disc. Coronary angiogram was done, which was normal, and she in fact is awaiting mitral valve replacement. Sorry for the typo. So she's yet to be operated. So in fact, we in fact reported a similar case of a mechanical damage to the tilting disc valve from our institute with fairly similar appearance as in our case, which again the echo showed a significant abnormal mobility. During systole, what we could see is it is crossing the swing ring and it is appearing within the left atrial cavity. Similar mechanical damage was reported with bileaflet valves as well. So to conclude, structural valve deterioration, leaflet fracture should be suspected in the presence of significant intervalvular regurgitation, especially if it is associated with abnormal mobility of the leaflets. Multimodality imaging like transesophageal echo and CT is useful during assessment. Early surgery is needed to prevent further complications like device embolization and catastrophic significant aortic regurgitation. Thank you.
Oh, thank you, Shanmusundaram. Very interesting case. Both the cases are very interesting. I'd like to know whether these patients had a slow deterioration or they presented with acute symptoms, both of them.
Sir, in fact, both of them had a slow deterioration. The first one had symptoms for the past 3 months, which in fact worsened for the past week. And the second one had function class 2 breathlessness for the past 3 months before the presentation.
What may be the reason that this over a short period these patients developed the valves, the valve disc was actually fractured? What may be the reason?
I couldn't really comment on this because probably the structural damage had happened over a period of time rather than all of a sudden. Though I couldn't really.
You need not tell me, but was it the same valve or is it a different valve?
Same valves.
Or both were the same?
Same valves.
Same valves. Okay. Any other comments or questions? Okay, if there are none, we'll go to the next speaker.
Thank you. So it's a pleasure to introduce our next speaker. Our next speaker is Dr. Liam Ring. Liam is a consultant cardiologist at West Suffolk Hospital in Bury St Edmunds. He's the co-chair of the Education Committee and a trustee of the British Society of Echocardiography. And Liam's going to present to us a simple case of valve disease. Thanks, Liam.
Thank you very much, and thank you for the invite. Yes, this is perhaps a little bit simpler, but hopefully we'll have fun. So, why is it not working? Sorry, guys. Best laid plans and all that. Let's try again. Is that working now?
Yeah, it's working.
Fantastic. So we've got a 55-year-old chap, no prior medical history, but presented to the hospital acutely with a relatively short history of progressive shortness of breath, palpitations, and features of heart failure. There's no family history of note. And on exam, he was tachycardic in atrial fibrillation. Blood pressure was a little bit low. JVP was up, very low volume carotid pulse with only a very soft systolic murmur notable, creps in the lungs and lots of edema. Relatively normal blood count, slightly impaired renal function, and a very high pro-NT BNP. His ECG looked a bit like this. So we can see AF, relatively tachycardic, some strain pattern towards the apex. And his echo pictures looked like this. So first take, obviously, visually at least, there appears to be an increased wall thickness and global reduction of contractility. Overall, I think most of us would agree that the ventricle is severely impaired. And visually, the aortic valve is quite calcified with restricted motion. So we took some measurements. His LVOT diameters marked there. And then we had some Doppler assessment, as we often do in aortic valve, as we should routinely do in the aortic valve. And of course, the patient was in AF. So then there's an immediate question as to the technique we should use to optimize assessment of that valve in a patient in AF. And there's a number of different methods we can choose. We can average a number of cycles of at least 5 to 10, something called the index beat method, or a matched RR interval method. And really, just as a brief summary, the averaging consecutive beats works pretty well as a way of averaging the total cardiac output. And most guidance, and indeed the BSE guidance, suggests that 5 to 10 consecutive beats, and it's important that they are consecutive beats, is appropriate. Of course, that's potentially time consuming, although many of the modern echo carts will have AI with an ability to auto interpret the curves, which makes it a little bit more useful and a bit easier. But the concern, I guess, is that some studies at least have suggested that you probably need up to around 20 consecutive cycles to actually average the cardiac output. So 5 to 10 may not be sufficient to get an accurate result. An index beat method is something that we've started to use quite a lot, and we reference in a lot of the British guidelines, is that very often if you've got a patient within atrial fibrillation or who is in atrial fibrillation, if you wait long enough, somewhere along the line, you'll get a run of 3 or 4 beats that appear relatively regular. And if you have 3 beats that are relatively regular with similar R to R intervals, the third beat in the row is actually an excellent assessment of average flow. And you can reliably use that single beat as a good assessment of overall valve function or whatever it may be. And then there's something called the matched RR interval, which is what I ultimately chose, or what we ultimately chose. So just as an example here, this is from our BSE guidance, and the top 2 images, A and B, demonstrate the sort of standard way of averaging a number of cycles. I think 8 cycles here for both continuous wave and pulse wave. And then the matched RR interval approach, as I've demonstrated here, is that you choose a long RR interval in AF and measure that gap in continuous wave. And you can see on this example in image C that RR interval is about 600 milliseconds. And then you similarly get your pulse wave Doppler out, measure, wait for there's a similar long RR interval, in this case around 607 milliseconds. And as they're quite similar, you can use those two, that single continuous wave and that single pulse wave tracing, as a way to assess your valve. So in this patient, we chose this matched RR interval method. And the other reason that that's useful is that by waiting for a relatively long RR cycle, you are maximizing as much as you can flow through that valve. And I think we can all appreciate that in a ventricle that's very impaired, there's relatively low flow through that valve. So you often get relatively low gradients, which makes it challenging with regards to interpreting the severity of that stenosis. And so by waiting for a long RR interval to maximize the flow, you can kind of get as close as you can almost to what that gradient would be in relatively normal flow states. So here you can see I chose 2 R2R cycles. The top left image, you can see that's an R2R cycle on a continuous wave Doppler. That's 618 milliseconds. Then I've done a pulse wave Doppler, and you can see that the RR2R cycle there is 636 milliseconds. So they're very close in terms of time. And then I've traced around it in the bottom left image and traced around the pulse wave Doppler in the bottom right image. And the indices we get were a Vmax of 3, a mean gradient of 20, and a valve area of 0.7. So despite my best efforts with this matched RR interval approach, we are still left in a scenario where we've got a valve that is slightly challenging to interpret, in as much as the gradient is low, which would be consistent obviously with moderate AS, but the valve area is small, consistent with severe AS. In terms of the patient well-being, we optimized his rate, gave him some diuretics. He had derived a significant symptomatic improvement. He underwent some coronary angiography, which demonstrated unobstructed arteries. And so we're then left at the situation as to how to interpret or how to investigate this person further to establish the true severity of that aortic stenosis. I mean, obviously our clinical suspicion is that it was severe. You know, why else would he have deteriorated? But it's nice to get that confirmatory evidence. So again, the BSE, we talk quite a lot about the different methods and approaches you can take in such a scenario. And we, as an echo society, sort of promote or talk a lot about dobutamine stress echo, which can be done in a variety of ways. And there's one particular way that's done using the projected methodology. And we talk about it quite a lot in the guideline, which people can go and read. As you also probably know, that there's no randomized trials, as it were, for the use of this methodology, but there are large databases of patients in whom it appears to predict outcomes and appears to be pretty good. But the challenge in this case was that the patient was pretty unwell and had decompensated. He was already in AF that was relatively tachycardic, and he had runs of non-sustained VT. And given all that, we were not necessarily convinced that DSC would be a sensible way forward, and we're not convinced it would necessarily give us an answer. And so after discussion in MDT, a decision was made to proceed to a calcium score of the valve, which was undertaken, and the calcium score was just over 3,000. And again, as I'm sure people know, a calcium score in a man of over 3,000 is usually consistent with severe AS. So on the basis of this, in his presentation, he went on to have a biological AVR implanted. And I guess a good question would be, in a chap who's 55, why was a biological AVR chosen? And although the patient was obviously committed to anticoagulation, he was on a DOAC by this point. He was very unkeen on the prospect of using warfarin and INR checks for the rest of his life. So with a kind of a patient-based approach, and the decision was made to go with a biological valve. So he actually went through surgery pretty well. In the immediate post-operative period, he came off bypass quite quickly, was back in sinus rhythm, and was obviously initiated an optimal medical therapy to treat his LV systolic dysfunction. And you can see the drugs that he was on there. And he had, as I said, responded very well and was discharged home by day 7. He did have a relatively early echo post-op, but things hadn't necessarily completely improved. So this is the first echo he had after operation, and you can see that things have dramatically improved. His ventricle has, to all intents and purposes, normalized. He's got good LV systolic function. His biological valve was well seated, and there was good and very satisfactory Doppler indices, which I've listed there. So a Vmax of 2.7 meters per second, a me gradient of less than 20, a DI of 0.5, and an effective orifice area of around 1.8 centimeters squared. And his pro-NT BNP, which you may recall was almost 7,000 at the point of admission, was now normal at 65. And he was completely well at this point, with 0 symptoms whatsoever. And in fact, had actually undertaken a new sort of change leaf and undertaken lots of exercise. So then, because he'd had such a dramatic presentation, I chose to see him a year after. A year later, so this is 24 months after his surgery, and he remained very well at this point. But on echocardiography, or on clinical exam and then echocardiography, there was quite a prominent murmur. So we went forward to scan him again, and despite the fact that he was very well with absolutely 0 symptoms, there was a dramatic change in those echo indices. So his LV systolic function still looks very good, but his Vmax has now increased up to 4.5 meters per second. And you might remember it was 2.7 relatively soon after his surgery. His mean gradient is now 50 millimeters of mercury, and his valve area, or his effective orifice area, has dropped to around 1 centimeter squared. So all of the indices are now in keeping with severe aortic stenosis. And as I said, he's been very compliant with his medication. He's not stopped taking anything, and he is now cycling to quite a high level with no symptoms whatsoever. So I guess this then raises a few questions which I thought we might wish to discuss in the panel. The first one is, what could explain that change in Doppler indices? Leading on from that, what should we do next? How can we proceed from here? What can we change in terms of his management, if that's the right thing? And another question is, which brought me back really to the original presentation, is, were we right in making the assumption that this was all related to severe aortic stenosis? Because if we were under the assumption that his severe AS caused LV impairment, why, when he's clearly got severe AS now, is his LV remain very good and he remains completely well? And that was, I think, a really interesting question. I'd just be interested if there's any comments from the panel as to what we should do next, what explained the Doppler indices, or whether his ventricle, whether he genuinely did have severe AS the first time round. Or am I not allowed to ask the panel?
No, I think there are scenarios where we sometimes see high gradients through replacement valves despite normal valve function, so pressure recovery and prosthesis mismatch, but they're evident from the moment of implant, aren't they? So the progression of high velocity and high gradients from normal post-implant, I think, suggests some valve deterioration.
Yep.
I think that's the first broad division that I'd make.
Yep. So that exactly that's exactly the sort of
I was just thinking whether this could be a tachycardiomyopathy. The patient had atrial fibrillation with a ventricular rate of 140, and whether and after the valve replacement and his ventricular function spontaneously improved with the sinus rhythm. So I was wondering whether this could be a case of tachycardiomyopathy where the patient went in for heart failure, and with the control of heart rate and back to normal sinus rhythm, the patient had a good improvement. What are your comments?
Yeah, I mean, that again was I guess is the question, with the benefit of hindsight, was his presentation entirely related to AF as opposed to purely related to the valve, which was the assumption at the time?
It may be a combination.
Or was it a combination of the
valve is there because he have found that the valve area is only 0.7 centimeter square. So obviously it's a significant aortic stenosis, and on top of that, tachycardiomyopathy also may be considered. I was just thinking.
No, I agree. I think that's an interesting point. I guess my worry was that if severe AS could be blamed for LV impairment, it's strange, isn't it, that this time when he's very clearly got severe aortic stenosis, his ventricle is perfect and he feels completely well and can run 10 minutes on a treadmill. So I think it's a really interesting scenario and how important potentially AF was in that. Okay, so that's true. So any plans as to what we should do next? Any thoughts about what the next course of action would be?
And my concern is this is bioprosthetic valve thrombosis leading to steady climbing gradients. So I'd send him for a CT and then I'd anticoagulate him almost regardless of what the CT shows, because you can miss thrombosis if the CT is not done very carefully. And if the gradient melts away with anticoagulation, you kind of made the diagnosis.
Sure. So let me share my screen with you again. So I took your view, Jim. In fact, I didn't even send for a CT because I just took the view that this was almost certainly valve thrombosis. And so I just stopped his DOAC and initiated him on warfarin. And this is quite dramatic, this was 2 months after initiation of warfarin. He continues to feel very well, but within 2 months, his Vmax has dropped back down from 4.5 down to 3.2. And remember, his baseline was only around about 2.7. So we're not far off from baseline now. He continues to do well. And my plan is to bring him back and check him again in about 6 months' time to hopefully see that we've got further improvement. I did think about sending for a CT, but in the end I chose not to. And when in partly because we have quite a long wait, and when I saw him back 2 months later and there was such a dramatic change, I kind of felt that supported that proposed diagnosis. But that I thought was an interesting case. Jim, I'm interested to think what you felt about the initial presentation and why there was such.
It's interesting. I've encountered this a few times where people have developed bioprosthetic thrombosis on a NOAC that has then improved with warfarin. So it is a signal that NOACs may not be sufficient or protective of this pathology. I mean, I suspect this is quite a fit man with quite a sort of good ventricle, and he was clearly coping with his aortic stenosis until he went into AF. So it is intriguing to know whether if he'd been sort of well rate controlled or possibly even cardioverted, would his ventricle have recovered? He would have needed an AVR soon anyway, wouldn't he? It would have been quite brave to cardiovert him and say, off you go, you'll be fine. So I think he would need an AVR anyway, but it's a good lesson that he can tolerate that stenosis without major symptoms. And I've seen that a few times. People are getting really quite severe elevation in gradients with minimal symptoms when it's valve thrombosis. It doesn't seem to behave the same way as, calcified stenotic native valve disease.
Yeah, I find that interesting. So because somebody was talking about how long the ventricle is exposed to the high gradient might be detrimental, but I would have assumed that if you take a ventricle that is relatively naive and suddenly expose it to a rapidly progressive gradient, it would likely impact on LV function more. And I find it interesting that valve went from normal to clearly very severely stenosed in the space of around 12 months. With absolutely zero impact on his ventricular function, his well-being. So I thought it was a really interesting sort of case of how well it was controlled. But and as you point out, the DOACs do not protect from this phenomenon. I'm not aware of any way of predicting in whom this will affect, because it does seem to be very variable. Obviously, we've got lots of patients with biological valves on no anticoagulation who do very well, and this guy had not gone back into AF at any point as far as we're aware subsequent to his surgery. So
the only risk factor I've come across in the literature is poor LV function, which sort of makes sense.
Right.
not opening the valve briskly and washing the sinuses.
Dr. Newton, I would like to know whether do you recommend DOAC in patients with valve replacement, or is it that this patient preferred that?
I presume in this case the patient preferred that. There's quite a bit of variety in practice, certainly in the UK. You know, quite a lot of surgeons will just recommend an antiplatelet agent for a bioprosthetic aortic valve if the patient's in sinus rhythm with good LV function. Other surgeons might recommend anticoagulation for 3 months and then an antiplatelet. Other centres will give nothing if the patient's in sinus rhythm. So there's wide variation in practice, and I think this is a more common pathology and problem than perhaps we realise. And I think there's a lot of low-level bioprosthetic valve thrombosis happening that we're not treating because we're not, let's say, diagnosing it. There's only a small climb in the gradients, but it does make me wonder whether we should be more proactive in anticoagulating patients, certainly those with poor LV function post-op, where I think there is a real risk.
Thank you, Jim. I think it's a very interesting case. Shall we go to the next speaker?
Perfect. Thank you very much.
Okay, thank you. I think we'll get back to you at the end of the after the presentation is completed. Now, the next speaker is Dr. Satish Govind. He's a consultant cardiologist at Narayana Institute of Cardiac Sciences. His area of interest is echocardiography. He has been the past president of the Indian Academy of Echocardiography, as well as he has contributed few chapters into the textbook of echocardiography of the Indian Academy of Echocardiography. So he is thoroughly into echocardiography, and we expect an excellent presentation from him. Satish, the floor is yours.
Thank you, Dr. Manjuran, and hello to all of you. So some wonderful cases and wonderful presentations, very interesting discussions. Prosthetic valve always brings out the difficult part of the valve assessment. So I'll be now focusing on something slightly different, where I'm looking at T, and in view of the limitations of time, I'll be focusing upon complications in mitral valve. Now, when it comes to T, we sort of look at the T as something about, sorry, what did I do? Yeah. So when we're looking at the T, what are the advantages? So one is it has very good resolution, especially when compared to transthoracic echo. And the mitral valve is a very good valve when it comes to looking at it. And when you combine it with 3D imaging, then you get a very high incremental value in terms of information and in terms of trying to come to a conclusion as to what next to do with the valve. And it's also very ideal for looking at small masses, which may not be visible on transthoracic echo, and very useful in paravalve leaks in terms of where it is located and sizing. And also the advantage of T is it can be done bedside. There are some limitations to T in terms of the operator skill. So better the skill, the better the output is going to be. And of course, T itself, though we expect the T to be the best possible imaging window when compared to TT, sometimes the window itself can be a little bit of a problem. So this also adds to the scenario. Now, the prosthetic valve, the journey of the mitral valve starts in the operation theater. So this is where the surgeon who takes the decision sort of determines how the valve is going to be for the valve and for the patient. So first and foremost is choosing the right valve in terms of size. So if the sizing is good, then a lot of things fall into place. And also the type of valve. So in terms of a good, whether it's a mechanical valve or a bioprosthetic valve, or it's a tilting disc or a bileaflet. So in terms of hemodynamics and how long it is going to last, and many other sort of pictures, the parameters come into play. And then for the surgeon also on table, what are the challenges? So the more calcified it is, the more difficult it is going to be. And if there's been a history of infective endocarditis of the valve, it's going to be a little more challenging. And of course, tissue quality can vary, and this can give rise to problems later. And surgical techniques, this is dependent on the surgeon who does it. And now with the advent of mini thoracotomy, so there are going to be some ups and downs with the valve itself. Now, after the valve is implanted, so this is where the true test of the valve is going to be. So the assessment before the chest is closed. So they have to make sure that the valve leaks are not there. So if there is any significant paravalve leak, then it is obviously they have to go in and do redo it. And looking at gradients, so have they put in a smaller valve, or is there some other reason why the gradients are high, and other sort of parameters also. Now, I'm going to go case by case. So this is patient 1. So here, looking at a bioprosthetic mitral valve. So there's obvious dysfunction. So we have these terminologies now: structural valve deterioration, structural valve dysfunction, or bioprosthetic valve degeneration. And then you have the valve failures also. So there have these definitions. And so here you can see that the valve cusps are totally immobile here, thickened, calcific, and definitely not mobile. And in addition to the stenotic part of it, there is a significant regurgitation which is happening. So it's a combination of both stenosis as well as regurgitation. And here you see a natural progression of the valve which has deteriorated over time. Now, moving on to patient 2. So here there is another bioprosthetic valve. So the degeneration is not as bad as it was in the previous patient, but definitely you see a small tissue tag in the 2D image where it is popping up. So that is where the valve where it has met the healthy part of the leaflet where it has broken off. So the so-called, if you can call it as a fractured cusp. And when you have a very eccentric jet and which is coming through this cusp, then you know that it is a cusp which is sort of fractured in between and it is giving way to the regurgitation. And on 3D, you can make out a small dimple over there. And the on-fast view gives the regurgitation coming from that area. So this is another type of complication which can occur with the bioprosthetic valve. Then, as was seen earlier with another type of valve by the earlier speaker, so here we have the valve degeneration where you have a thrombus. So this is very extreme. So we have multiple thrombi which are sitting all over the place, both on the atrial side as well as the ventricular side. And T can give you very nice images, both with the bioprosthetic valve, both on the atrial and ventricular side, and you can see the spread of the thrombus itself in different places. And one can monitor how these thrombi behave over a period of time. So this again is part of the structural valve dysfunction which happens. So part of the natural course, the natural history of the valve itself. Now, the next is another patient where you have an extreme here. So there is a valve which has got paravalve leak, and where you have more than 30% of the circumference of the valve which has been involved. And you have a profuse torrential regurgitation happening through it. So this is a dehiscent valve, and of course, this has to be replaced. And this again is another extreme of how valves can go wrong. And here it could be because of the surgical technique that has been used, or a tissue quality which was there earlier as a substrate, or like an infective endocarditis or a calcified area. So these sort of tend to initiate the dehiscence, and over a period of time, the small leaks become bigger and bigger, and then it becomes a dehiscent valve. And then moving on from bioprosthetic valves, so now looking at mechanical valves. So this is a mechanical bileaflet valve, and you can see that there is one disc which is totally immobile. It is stuck, and you have the turbulent flow through the other orifice. And here the problem, the why it has happened is because it could be due to two reasons. One is patient compliance, where patient has not been taking the tablets, the anticoagulants regularly, or it could be anticoagulant dosage which has been inadequate or improperly sort of advised, and this can result in an obstructed valve, and this is where a thrombus can sit over the valve, and it can be a minor restriction to a complete obstruction, as you can see it. And then T, of course, can give you invaluable sort of information. You can see that the layering of the thrombus over the disc, and it is extending into the left atrial appendage, and that's how the information can be provided. And then another patient here. So again, one more obstruction here. So again, you can see the thrombus over there very clearly, but here you see a lot of regurgitation. So any turbulent flow within the chamber where we have to assume like it is going to be a pathological regurgitation. And here, invariably, we think in terms of a paravalve leak, but here you can see that the regurgitation is occurring within the sewing ring, and it is coming because of inadequate seating of the disc as it sort of closes, or it's leaving a small gap, and that's where the regurgitation is happening. An example of regurgitation due to stuck valve. So this is two sides of one coin of an obstruction due to thrombus. And then you have the mechanical valve where we can get involved, just like the native valve, which can have some structural abnormalities and which is predisposed to infective endocarditis. So similarly, the prosthetic valve also are prone for infective endocarditis. And here's an example of mechanical valve. You can see that the vegetations are quite sort of extensive. It is sort of layered over the orifice itself and causing significant obstruction. So vegetation can cause obstruction, can be a focus of emboli, can cause adjacent sort of abscess. So there are many ways the infective endocarditis is present. So this is one way of the presentation of infection with endocarditis or vegetation causing obstruction. Then the other complication that can happen is the paravalve leak. So here's an example of a mechanical valve, a bileaflet valve. The discs are moving well. It's a medial leak. You can see it's a very profuse regurgitation, which is coming on the medial side, and with the 3D, you're able to characterize the type of defect over there and what is the shape, size. And this is where the advantage is, if at all, if one is trying to plan device closure. So T can give you a very sort of useful information. And this again could be the substrate could have been a surgical technique or tissue quality due to various reasons, or that could have led to this paravalve leak. And then there is another type of valve. So this is the ball and cage valve. And this patient came with two paravalvular devices for a paravalve leak closure. So you can see on T two devices sitting on either side. And you can see that there is a residual regurgitation which is there. And but what is interesting is that the gradients which are seen are very high. So this again is disproportional to the paravalve leaks. We do expect some high gradients because of flow-related issues, but and when you take a closer look, so this again using 3DT, looking at both the LV side and the LA side, you have these tissue overgrowth over the sewing ring, which is quite extensive, which is sort of encroaching into the orifice and causing this obstruction. So the older the valve, the more likely pannus can be, and sometimes they come in complete packages like this, which is not good for the patient, but they do provide for some very interesting images. And lastly, apart from the prosthetic valves, we do have a lot of repairs which are going on now, and we have these various types of rings which are being put in. So this is a D ring, which is completely sort of enclosing the annulus over there. And one can see that there are two jets which are coming. So there is a big jet coming through the orifice because of the malcoaptation of the leaflets. And there's also a smaller jet coming from outside. So this is a paraprosthetic leak. And usually it comes posteriorly. So this is where the surgeon has a difficult sort of view, and these things can go wrong here. And also the tissue, because the circumflex artery coming here also, they are extra careful. And so this is when the bite of the stitch doesn't happen and things can go wrong at this point. So this is a classic case of a paraprosthetic leak occurring posteriorly. And again, you can assess this in terms of the size and where it is. So this patient, we actually put a device for the close, and we close it successfully. So an example of a prosthetic valve ring having a paraprosthetic leak. So when you are looking at T and when you compare it with the other imaging modalities, so definitely TT is going to be the initial imaging modalities, so the screening part of it. And based on that, you have a T and CT over there. And you can see that T has got a lot of pluses in terms of what information it can provide, provided it is done judiciously, and then it is done with the skill and the information to back up the T skills. And then, of course, CT has got its own sort of advantages. So it's a balance between these two. And CMR has got its own value over there. And as far as the guidelines, there are many sort of guidelines, many algorithms that are there. So looking at how to assess the severity of prosthetic valve regurgitation. So yeah, it's almost similar to the native valve. So you have this mild, moderate, severe, and a lot of these other parameters are there. And then the same thing goes for prosthetic valve obstruction. So similar to the native valve, so the stenotic, the parameters. So except that instead of a valve area, we are looking at an orifice area here. And there's a lot of emphasis on the Doppler velocity index and the effective orifice area apart from the gradients. And of course, you have these various algorithms to make our life easy. And it's up to us to choose how to use these algorithms and where T comes in and provides us meaningful information for management of patient. Thank you.
Thank you for giving such an elaborate description of the complications of prosthetic valve. I would like to know how frequently do you come across the valve abscess, especially aortic valve abscess following a prosthetic valve infection?
The aortic root abscess, comparatively, when you compare it with the mitral valve, it's a little more, and especially which is the aortomitral curtain, which is very close by. So that is the vulnerable area where it gets affected. So in terms of the abscess, it can occur in different ways. You can have a small abscess, a thickening of the abscess, or it can cause small aneurysms. And these aneurysms can get bigger, and sometimes it can be associated with paravalvular leaks. So it does happen. So there's a high possibility whenever there's a vegetation of the infected endocarditis of the aortic valve. The mitral valve is comparatively less in terms of occurrence, especially the abscess part of it.
Okay. Any other comments? Any questions? Because we can at the end we can have a little more discussion. So we'll go to the please. Can we have the next speaker?
Thank you. Yeah, it's a pleasure to introduce Dr. Sushma Rekhraj. Sushma is a consultant cardiologist at Nottingham City University Hospitals and a trustee of the British Society of Echo. And Sushma is going to present a case of mitral valve intervention. Thanks, Sushma.
Great, thank you very much. Yeah, there will be a fair bit of overlap with the previous speaker, so apologies for that. My case is a 78-year-old man who had previously had a bioprosthetic mitral valve replacement in 2003 with a 29mm Sorin valve. This was done for severe mitral regurgitation due to mitral valve prolapse. He also has a past medical history of COPD, Raynaud's, and chronic kidney disease. And he'd been doing pretty well. Until he presented about 9 years later. He presented with some breathlessness, and as you can see, his bioprosthetic valve was now started becoming severely stenosed, degenerative changes. You can see the valve leaflets are very thickened and restricted with flow acceleration through the valve leaflets and a mild central leak, mild regurgitation, apologies. With this, his mean mitral valve gradient had gone up to 18. And you can see on the lower images, or 3D images that were taken, the one on the left shows the mitral valve from the left atrial side, and the one on the right is from the LV side. And you can appreciate that the valve leaflets are significantly thickened and extremely restricted. So not surprisingly, his mean gradients had gone up significantly, and he had become symptomatic. And he went on to have another bioprosthetic valve. I'm not clear the reasons behind that, but he had a 31mm EPIC stented porcine bioprosthetic valve, and post-operatively he went into complete heart block and ended up having a dual chamber pacemaker. Now this eventually got upgraded to a CRTP device in 2021 as his LV function started to deteriorate and he was becoming symptomatic with heart failure symptoms. And in addition to optimizing his heart failure medication, the device was also upgraded to a CRTP device. And he felt better in himself, and his LV did improve with this. Somewhere along the line after that, he did go into atrial flutter, and but overall was feeling a lot better. He was followed up in his local hospital until last year when he was referred back to our center, and this was due to increased symptoms of breathlessness and lethargy. Now, on examination, he had a neopansystolic murmur, but no clinical signs of heart failure. But at that stage, he'd already been started on heart failure medication and was on some diuretics as well. His ECG showed he was in a paced rhythm, and a blood panel was done, and it showed he was mildly anemic, a hemoglobin of 105 grams per liter, and it was iron deficient. The blood test didn't suggest hemolysis. He had normal inflammatory markers. So he went on to have a repeat transthoracic echocardiogram. And as you can see, the LV was mildly impaired, but the biprosthetic mitral valve appeared to be well seated and not rocking. And on this transthoracic echo, they found new evidence of a paravalvular leak, which was not seen on his previous echo imaging. So following on from that, he went on to have a transesophageal echocardiogram. And as you can see, the mitral valve leaflets appear quite thin and mobile, and the valve itself appeared to be well seated, but there is a significant paravalvular leak that you can see on the medial aspect of that bioprosthetic valve. And so the valve was interrogated with various views. And again, you can see this significant paravalvular leak on the medial aspect of this bioprosthetic valve. In addition to this, his E velocities were raised, and this is CW Doppler through the MR, which is a sort of a high density signal. So in view of his symptoms and the findings of his TOE, he went on to have a procedure. In fact, this was only done, well, before I come to that, let me just show you a bit more echo imaging. This was his 3D images. You can see that his mitral valve leaflets are a little bit thickened, but opening fine, and you can appreciate the paravalvular leak quite nicely on the 3D with color. And on measurement, this defect, it was a single defect measuring 7 by 3.5 millimeters. So it was discussed at our MDT, and in view of his symptoms, he went on to then have a paravalvular leak closure. And these are some images of the fluoroscopy for the procedure that was done recently. This was done via an antegrade approach. So they did a transeptal puncture, and they passed a wire through the defect, and through that, further catheter was passed through it, and then an AVP3 plug was implanted, retracted back into the defect, and this is after it was released and sitting quite nicely. So this was the images on the fluoroscopy, and let me show you what it looked like on the TOE, peri-procedure TOE that was done at the same time. So this was his peri-procedure TO imaging. So at the start, as shown previously, he had that significant medial paravalvular leak. This was the transeptal puncture. They ensured that the puncture was quite posterior and inferior so that they had a good approach for this, the location of the defect. A wire crossed the defect, and with the wire crossing the defect, it's not surprising the regurgitation got a little bit worse. But we're quite happy with the how the procedure was going. And then following on from that, the plug was advanced into the left ventricle and then pulled back. And you can see that the plug is placed quite nicely, occluding that defect and not causing any sort of obstruction to that bioprosthetic valve. Following the plug implantation, you can see that there's very trivial paravalvular leak left, which should hopefully improve with time as the plug settles in place. There's very trivial central mitral regurgitation, and you can see quite nicely that the forward flow velocity has come down once the plug has been implanted, and with that, the mean gradient had come down from 6 at the start to 3 at the end of the procedure, indicating a good treatment with the plug. And if I just show you some 3D pictures of the pre and post plug, and you'll see on the left, this is before the plug went in, and this is where the paravalvular leak was, and post-plug implantation. This was an AVP3 plug. I think it was a 14 by 5 millimeter plug that was implanted, and has been a very good response in terms of the paravalvular leak. So we were quite happy with the imaging that was obtained. And not only that, on imaging, we also found that there was a good hemodynamic response. So at the start, there was systolic flow reversal in the pulmonary vein, which at the end of the procedure was systolic blunting. And in addition, on the hemodynamics, invasive hemodynamics, we found that the mean LA gradient had come down from 15 to 9. And in addition, you can see that the V wave has reduced significantly. It started off as 24 and had come down to 16 by the end of the procedure. So just a brief slide about paravalvular leaks. As already sort of alluded in my talk, the kind of symptoms patients present with can range from a murmur to heart failure to hemolysis. So it's important to screen for all this. We would always start with a transthoracic echocardiogram to assess for a paravalvular leak or any other prosthetic valve dysfunction. The important thing to note is paravalvular leaks may be a bit more tricky to identify, so you may need to do off-axis imaging to identify the leaks. We tend to go on to do a transesophageal echocardiogram to further assess the anatomy and the degree of the regurgitation. And as already mentioned, a hemolysis screen and blood cultures is important to ensure that there's no underlying infection. Now, in our patient, we didn't see any evidence of acute infection when he'd been seen in clinic. Now, in terms of how to manage these patients, if it's mild, then you just monitor it. Now, if it's moderate or severe, then you need to sort of decide, is the patient asymptomatic or symptomatic? Is further information required? So further imaging has been used in certain situations. So occasionally we have used CT to help size these defects, especially if it's a mechanical valve that has caused a lot of artifact on the TOE. The CT has been very helpful with that. And sometimes we've also needed to use MRI to further assess the degree of regurgitation. So in our case, so the patient is symptomatic, then you need to decide what are the options, surgery versus a percutaneous closure. Now, surgery is usually for patients who've got active endocarditis, or if there's a large defect or a rocking valve, then they should definitely be going for a surgical repair replacement. In majority of the cases, we find that usually we are able to treat these patients with the TOE-guided percutaneous closure, as we did with our patient. And at the end of the procedure, we were very happy with the end result. As I said, this procedure was only done a couple of weeks ago, so he's planned to have a repeat echo in about 6 weeks' time and a clinic follow-up. So hopefully symptomatically, he will find some symptomatic benefit. So to conclude, this is a case of a patient who had a redo MVR and then followed by a paravalvular leak, which was treated successfully percutaneously with an AVP3 plug. Thank you very much.
Thank you, Sushma. That was brilliant. Just a couple of very quick questions. How often do we see hemolysis associated with paravalvular leaks? And is there a particular position, mitral or aortic, that we would expect to see it more commonly?
Well, hemolysis, I mean, as I said, patients can present with heart failure or hemolysis or both. I think from the literature, from memory, I think it's about 40%, and the different degrees of hemolysis as well. And as you can see in patients, they are elderly as well. So sometimes there's a little bit of mixture of iron deficiency, anemia as well. In terms of the frequency, are you asking the frequency of leaks in terms of the position or frequency of hemolysis?
Is hemolysis more associated with a paramitral or para-aortic position leak, or is there any difference on that?
I'm not sure that there is evidence to suggest one is more than the other. I think it's more to do with the size of the leak, and because the more restricted, the more hemolysis they get. I'm not aware that, the positioning, whether it's aortic or mitral, actually makes a difference from that respect.
So what is the reason for this paravalvular leak? Is it a surgical problem, or the patient had an infection like infective endocarditis? What is the mechanism which ultimately led to this paravalvular leak?
Well, that's the mystery, really, because at the time of the surgery, looking at the operative note, that they were quite happy with the result. The post-operative echoes were all fine. He didn't have any evidence of infection at the time when we assessed him. He could have had a silent infection that was treated for something else. It's very hard to be clear for sure. I suspect he may have had an infection that healed up and then he developed the leak, but it's very hard to know because it was, some years after his previous operation, and he had no regurgitation on his previous echo imaging. So it is a mystery.
Okay, thank you. Shall we go to the last speaker? The last speaker
Yes.
is Rajesh Nair. He is a professor and head of the Department of Cardiology at Medical College, Kozhikode. He has great interest in echocardiography, at the same time interventions. He does a lot of structural interventions in patients with valve complications. He does structural interventions, and he is presenting a very interesting case. Rajesh, the floor is yours.
Sir, my slides are visible?
Yeah, you are visible. Slide, I do not know. You have to project it.
Yeah. Is it visible now?
No.
No. Share slides.
Can you see it now?
Yeah, now it's better, I think. Yeah, good.
Yeah, now it is.
Now
You can enlarge it now, huh?
Okay.
Yeah.
Good evening, all, and thanks for the invitation. This is a case of a rare complication following mitral valve surgery, and we fixed it with a device. That is a device closure of LVRS shunt after mitral valve replacement, just using only local anesthesia and only transthoracic guidance. This is a history of a 52-year-old female who had mitral valve replacement in 2010 for severe calcific MS with a single tilting disc valve. She was diagnosed to have LVRS shunt in 2015, that is after 5 years, when she presented with history of heart failure. She was advised surgery, but she was not willing for surgery. So she went on with heart failure symptoms for about 9 years and finally landed up in very sick stage with cardiac ataxia, advanced heart failure. On examination, she had huge heart, rosary valve clicks were normal. There were features of pulmonary artery hypertension, a loud pansystolic murmur at the lower left sternal border. So we admitted her, stabilized her, and subsequent caps showed a QP by QS of 2.14 and pulmonary artery systolic pressure of 75. The degree of hemodynamic issues shown in the X-ray, the main pulmonary artery is hugely dilated, right atrium is enlarged, LV apex is very prominent, and severe pulmonary venous hypertension. So the patient was taken for a cardiothoracic conference, and she was declared unfit for GA by the anesthesia department. The surgeon told he won't touch the patient. She was terminally ill. Patient had even difficulty to cooperate for a TE examination because of severe dyspnea. So TE guidance is impossible in the cath lab as GA is not ready. The issue is, mine is a government sector where everything is done free of cost. So we have resource limitations. We don't have intracardiac echo. So this is the echo which shows the LVRS shunt. LVRS shunt is of 3 types. That is supravalvular, that is above the septal tricuspid leaflet, which is type 1, which is the commonest. Type 2 is the infravalvular, that is below the septal leaflet, which goes into the RA through a defect in the tricuspid leaflet. And 3 is the combination of both. So this defect can be an elongated type, it can be a flap-like type, or a fistulous type, or a cystic type, or a windsock type. Now, this classification by Sakakibara and Kono, the commonest type is type 1, and that is called the true gerbold defect. This is how the type 2 gerboard looks like, that through a defect in the septal tricuspid leaflet, the jet will be entering into the right atrium. So this is the final assessment by transesophageal echo. Somehow I could do it. So from this, it is very clear that the defect is above the septal tricuspid leaflet, and it is a type 1 gerboard defect. Actually, the acquired LVR shunt cannot be called gerboard, because gerboard means it is congenital. So indications for closure of LVR shunt following surgical procedures include heart failure, RV volume overload, and pulmonary hypertension. And my patient had all the three complications. Surgery is not that easy because it is associated with a complication of mortality of 42%. So this option of device closure was discussed with the patient and bystanders, and they agreed. Only type 1 defects are closed in the literature. I had my apprehensions of risk of worsening of TR, heart blocks. Now, no G available, no TE available. So I had real apprehension. So in the series of Shakil Qureshi, he had complications like secondary TR and a few conduction defects. In the largest case series by Shimin, where he collected the details of 28 congenital and 82 acquired, they have closed around 14 cases by intervention. So that gave me strength, and I thought I will proceed with intervention. So it was done under local anesthesia, sedation with metazolam, IE prophylaxis, heparin. So we crossed from LV to RA. Then how to deploy the device, whether to deploy the device from RA side to LV or from LV side to RA. There are two ways. So this is the LV angiogram. It shows the LV shunt. The right atrium is fully opacifying. So I had to use multiple catheters to orient towards the defect, and finally I had to take a Lima catheter. So here you can see the wire coming through the Lima into the right atrium, and this wire was pushed down into the inferior vena cava, from where it was snared out to create a LVR shunt. Now, this is can you see the marker? Okay, so now I am introducing Amplat's torque tube delivery system through the defect into the aorta. And you can see here in the next film, that is the device coming. And this is the device. And so the first disc was deployed very well up in the aorta, because otherwise there is a chance that the device entire system can jump out. So here the device was deployed very carefully. Here we used transthoracic echo. Luckily, her transthoracic echo window was very good. This valve has an issue that this occluder is not radio opaque. So our entire business is only by transthoracic echo. Now you can see I have released the device after full evaluation by transthoracic echo, and then LV angiogram showed there was no significant leak. So this was the final echo after deployment of the device. So this complication, that is acquired LVR shunt, can occur after AVR, MVR, aortic root surgery, VSD closure, or subaortic membrane resection. It can also follow after endocarditis, after trauma. One case report is there which occurred after an RC occlusion in acute MI. Then interventional procedures like endomyocardial biopsy and AV nodal ablation may be associated with this complication. During aortic valve replacement, when the surgeon does aggressive debridement below the non-coronary cusp, it can lead to damage to the membranous septum, and this complication can happen. Now, my patient had mitral valve replacement. Here again, when the surgeon goes ahead with the aggressive debridement of the calcified annulus, when the posteromedial commissure region is affected, this complication can occur. What happens is this starts as a very small communication in the flabby heart during surgery. The surgeon may not know this defect, and as time elapses, the size of the defect will go on increasing. Now, just a word about a congenital communication that is called the gerbo defect. So we had a girl, a 19-year-old, who has been under our follow-up for long with LVR shunt, where we repeatedly advised her to undergo the surgery, but she was reluctant. She later came with a class 3 dyspnea. She had cardiomegaly, LV type of epics. So this, you can see that the septal tricuspid leaflet is actually tethered to the septum, and I thought it is type 2 gerbo defect. So I told the patient that this you have to undergo surgery and no device is possible. But they were absolutely reluctant, and then I thought I will do a transesophageal echo. Now, echo differentiation of LVRA shunt from VSD is very important. Whenever you see atypical jet directions, persistent shunt flow into diastole, lack of ventricular septal flattening, no RV hypertrophy, normal diastolic PA pressure from estimated PR velocity, you should be cautious in diagnosing a simple VSD. The first clue for you to diagnose LVRA shunt is this thing, that is a bidirectional TR jet. That is a TR jet seen both below and above the baseline. This is the first hint that you are probably interpreting a LVRA shunt as a TR. So if you take the velocity 4.96 and the gradient is 98, I think it is pulmonary artery hypertension. And this has been reported in the literature that patients are erroneously labeled as having severe pulmonary artery hypertension. So now I did a transesophageal echo. Anyway, she was not willing for surgery. So here clearly you can see that LV outflow tract is communicating to right atrium. Now, I'm not an expert in echo like any one of you, but there's no division of cardiology into interventional or echo. Here we have to do everything. So sort of jack of all trades and master of none. So I did a esophageal echo with a 3D. And again, all the consultants felt that it's a type 1 and not type 2. So I thought, anyway, she's not willing for surgery, and I will go ahead with device closure, and it was done. So again, the LV angio shows the severe opacification of the right atrium. So you can see that through the defect, I am introducing the catheter into the right atrium. Here, I didn't make a AV loop. Instead, I introduced a very stiff wire through the defect into the inferior vena cava, and over which I introduced again that embolizer torque delivery system. And the device was brought and under transthoracic echo guidance, it was deployed. Then the pigtail was first removed before releasing the device, otherwise it can dislodge. And then the device was deployed. You can see the device getting deployed. So device was deployed across the defect. Then the echo was repeated. There is not even a trickle of LVRA shunt or VSD. Now, in other views, to my surprise, shocking me, actually, I found that the device is holding the septal tricuspid leaflet. That is, one disc is in the left ventricle, the middle part has gone through the defect in the septal tricuspid leaflet, and the other disc is actually catching the leaflet, and the entire leaflet is plastered to the septum. But still, that happened. There was nothing, no trickle of air. So I was really fortunate. Patient was really fortunate. So probably this was an inadvertent closure of a type 2 LVRA shunt. So you can see in 3D the septal tricuspid leaflet is actually being held by that device. So differentiation of different types of LVRA shunt may not be very easy by echo, where even transesophageal echo can be confusing. Acquired LVRA shunt after mitral or aortic valve replacement is an extremely rare complication. It can be safely closed with a device. The redo surgery carries a mortality of 42%. We could discharge the patient on the second day after the procedure, where after surgery, it will be a very long hospital stay. So in extremely sick patients who are unfit for GA, this procedure can be done just with fluoro and transthoracic guidance in a resource poor setting like mine. So type 1 and also type 2 gerbo defects can be closed percutaneously. Thank you.
Thank you, Rajesh. Rajesh, have you seen in any other case of similar nature where there was a LVRA shunt? Because I have never seen such a case. So did you have the experience of another case, or this is the only one that you have seen?
Yes, sir. I have seen only 2 cases in the last 28 years. The other patient was absolutely not willing for anything. So she subsequently lost for follow-up.
What may be the mechanism which ultimately resulted in this shunt?
This is due to excessive debridement of the annulus in very calcified valve. So what happens is during surgery, when the heart is flabby, after the excessive debridement, the surgeon may not note the small hole. So it may be a really very small one, but unlike the congenital alveoration, the acquired tissue tear will go on increasing as the time elapses. So this may not be even picked up during intraoperative TE because when the heart is flabby, when the blood pressure is low, such shunts may not be visible. So we have told now our surgeon that whenever they are doing such valve replacement in extremely calcified valves, we ask the anesthetist perfusionist to distend the heart and make the blood pressure up to minimum 110, and then only look for such residual shunts. Otherwise, we will miss it.
But if the shunt is because as I circulate to the debridement of the calcium,
Yeah,
do you
calcium.
think that the more likely the shunt may be from left atrium to right atrium rather than LV to RA?
So actually, if it is the posterior annulus, that region they debride, that membranous septum can be damaged. That is what they have shown in their CVTS journals. I'm not very sure what exactly is happening.
Any other comments? It's a very interesting case and which was closed with a device closure and very wonderful case. Any other comments, questions?
Jimmy, I would agree. A very interesting case and an excellent outcome with a very good procedure. And I wouldn't have thought to do it with transthoracic only, but clearly that is feasible. So it's very helpful. Thank you.
Thank you.
So there were 3 questions in the chat box, and 2 have been answered on the chat box itself. One question still to be answered is high gradient across metallic mitral prosthesis in an anemic patient, no atrial fibrillation, normal systolic function. What should be done?
Well, I would anybody would like to take up the challenge?
As Jim here, yeah, happy to answer that. I mean, that's one of the sort of questions that comes up in the guidelines. I mean, I think what the question's postulating is this is sort of dynamic high cardiac outputs because of anemia. So the first thing to cross-check is, have you got high flow everywhere? Your LVOT stroke volume should be up. It's not necessarily just the gradient across the prosthetic valve. And if you confirm that you're in a hyperdynamic status because of the anemia, then I wouldn't do anything other than correct the anemia and reassess with another echo when the hemoglobin's back to baseline. If you correct the anemia and the gradient remains high, then that's obviously potentially a different pathology.
So for patients who are watching us on YouTube, I think we'll have to answer the questions which are already in the chat box because they may not have an access to this. So the first question which was asked was, how useful is 3D echo in diagnosing structural dysfunction of aortic prosthetic valve? And it was answered by Dr. Jim Newton. That is, it is less helpful for mitral valves, but can complement 2D imaging data and is very helpful for using multiplanar reconstruction to measure paravalvular leak, location, size, and shape.
Yeah, I can expand on that. I mean, it's not as useful as mitral simply because it's not orthogonal to the imaging beam, and you don't get such good reflection from the prosthetic aortic leaflets, and you still get a lot of artifacts. But I do find it helpful for assessing aortic paravalvular pathology, in particular trying to decide where are the defects, how many are there, what size are they. You saw in Sushma's case, measuring the size of the defect is quite important for choosing the right size vascular plug. And the best way to do that is with 3D.
I think the moderators can give their closing comments because of the time.
Okay, there is one more question. Simi, are you reading the one?
Yeah.
We can give final comments.
Yeah, this is for Dr. Lam. Was T done for your case? And because we were struggling with the answer whether it was a thrombus in valve, and we treated him with anticoagulants and he improved, and we retrospectively thought that it was a thrombus. Another is that in such a patient who has a bioprosthetic valve, if the patient in case needs a redo, he can be definitely offered a valve-in-valve, something like TAVR for a bioprosthetic valve. You can just reply briefly, sir. You already answered it, but
yeah, I mean, you've summarised the answer very nicely. I didn't think any further imaging was needed because it seemed very likely to be a thrombus. So we treated it and he got better, which seems like it's confirmed what we thought. And then I guess if he did need a redo, something else could have been done. Yeah, Sean.
Could I just ask if you'd converted him to sinus rhythm before the AVR and his LV returned to normal, would that have changed your mind about management and AVR at that time?
Yeah, there's a lot of ifs, isn't there? I guess if it had normalized and he felt better, I think I probably would have done. And now, having seen this, if it were to happen again, I might consider it. But at the time, he was pretty unwell, and so, and also he's 55, and he's obviously got an abnormal valve. So much as Jim was saying when we spoke about it, that it seems so overwhelmingly likely that it was aortic valve disease. But it goes to show that we should. There are sometimes occasions when it might not be the whole story, and AF was probably the most potentially more important impact in that patient at that time. Yeah, I mean, I guess the one thing I would have done if we'd gone back is give him a mechanical valve. He's obviously committed to warfarin now, and the mechanical valve would have done him very nicely. But that we are where we are.
Okay. Okay. Rajesh, can you stop sharing your screen?
Oh.
Okay. I think it was a wonderful session. I think of the speakers, Jim gave us a good overall idea about the prosthetic valve assessment and how to proceed with detection of the complications. And Shanmugasundaram gave a very unusual case where the disc was broken, and that has resulted in severe regurgitation, and these patients were surgically managed, and both of them are doing very well. And Liam showed a case of where the structural intervention, where the patient with atrial fibrillation would develop heart failure, and maybe because of a tachycardiomyopathy, but the patient had thrombus and severe aortic stenosis, and he was surgically treated, and the patient showed good improvement. And Satish Govind gave an overall assessment of the prosthetic valve with the use of transesophageal echo, and he showed beautiful images of paravalvular leak and how it can be surgically, how it can be treated. And Sushma gave us a good description of the paravalvular leak being treated by in structural intervention and how the patient improved following that. And finally, Rajesh Nair gave us an unusual case where after 4 years of valve replacement, patient presented with LVRA shunt, which was a structure which was interventionally closed, and the patient significantly improved, and that was a fantastic case. And after all, it was a learning experience, and there were many.
Any concluding remarks by Sean?
Sean, yeah, I think please close the session after your concluding comments, remarks.
Thank you very much. Yeah, just to say that it's been an excellent session, some incredibly interesting cases presented. Learned a lot myself, so I think it's a really helpful and useful webinar, and hopefully the first of many collaborations between the BSc and the Indian Academy of Echo. So thank you very much to all of our speakers, our moderators and our organisers, and looking forward to seeing you all on the next one.
Thank you, Sean. Thank you all. Thank you.
Thank you. Goodbye.